one of the issues, and I think it's been a barrier to progress in developing treatments that can fundamentally change outcomes in myeloproliferative neoplasms, is the endpoints of the clinical trials we're using. And so, originally as kind of a compromise with FDA, focusing on measurable things like symptom score improvement and size of the spleen or shrinkage of the spleen were, I think, reasonable. At this point, I think we need to look at outcomes that are more closely relevant to the patients. Certainly, patients want to feel better, but they also want to live longer while they're feeling better. And one of the major concerns that patients have is progression of their disease, either to a more advanced form of myelofibrosis or from one of the more indolent diseases like essential thrombocythemia or polycythemia vera to a more aggressive disease. And I think our clinical trials do nothing to address those concerns. And, I've kind of made this quip before, but if you set out to wash half of your car, that's your goal, you're going to get half a car washed. So if you set out to find drugs that will shrink a spleen and make people feel better, you will find drugs that shrink a spleen and make people feel better. But I think that you have to change those outcomes to be able to identify agents that are actually prolonging survival, prolonging event-free survival. And so that's a long prelude to what we were trying to accomplish, is identifying a potential biomarker that could help shorten to provide a surrogate for these outcomes that could shorten the time that would be required for these clinical trials. Progression, survival, thrombosis, even, those can take years to decades to reach enough events for a clinical trial to prove anything. And that has made it really prohibitively expensive for some of these diseases to include as endpoints. And so what we wanted to do is try to identify a way where from even a peripheral blood sample, we could identify changes that predicted outcomes in the near term. And the way we did that is acknowledging that these diseases are malignancies of hematopoietic stem cells, that to manifest a clinical phenotype require those stem cells to contribute blood cells, the process of hematopoiesis. And we really just set out to measure that contribution of the malignant cells to hematopoiesis from a blood sample where there are always circulating stem cells to analyze. And what we found was we could encapsulate that contribution. So technically what we did is we separated the blood into many different component cell types. And then we kind of built a model around that to allow us to understand how that contribution contributed to event risk. And we were able to show that people who had what we call increased fitness or high fitness level had a high risk for events. And we showed that drugs or approaches that reduced fitness prolonged the time before adverse events occurred. And so this, we're hoping can be turned into something that could be used as a surrogate endpoint to shorten the duration of these clinical trials while also focusing on what I think is dearly needed, which are endpoints that improve the quantity and quality of life for patients.